Welcome to Let's Chat About, the free monthly webinar series hosted by Hope and Focus, formerly known as Sophia Sees Hope. We've developed the series with those living with Leber congenital amaurosis and inherited retinal diseases in mind, but it is open to anyone who is interested in what's happening in our communities. My name is Alyssa Bass, and I'm the Director of Marketing and Communications for Hope and Focus. Before we get started, I want to take a moment to thank our sponsors for this series: AGTC, Dominion Energy, Janssen, MeiraGTx, ProCure, and Spark Therapeutics. We could not provide programs such as these without their support. A few housekeeping items. The session will last about 45 minutes. We did collect questions in advance from the registrations. There are a lot of those questions. We're going to take those first. As time allows, we will take questions that come in live. You can use the Q&A function in the webinar. We are recording this session, and after the webinar, we will post it to our YouTube channel. It's my pleasure today to welcome Dr. Michel Michaelides, Head of Clinical Ophthalmology at MeiraGTx. Mike is a founding member of MeiraGTx and a professor of ophthalmology at the University College London Institute of Ophthalmology in the Department of Genetics. He is a consultant ophthalmologist at Moorfields Eye Hospital in the departments of inherited eye disease, medical retina, and pediatric ophthalmology. He is currently the principal investigator of 3 active interventional clinical trials and has 10 ongoing ethically approved studies, including 6 in-house natural history studies and a multi-center international natural history study. Mike was awarded a medical retina and genetics clinical fellowship at MEH and a combined ophthalmic genetics and pediatric ophthalmology clinical and research fellowship at Casey Eye Institute. He is a recipient of a Career Development Award from the Foundation Fighting Blindness, an award that's rarely given to non-US applicants, and he has gained membership of the highly prestigious Macular Society and Retina Society in the USA. Welcome, and thank you so much for taking time to join us today.
My pleasure.
So we're going to dive right in. Please talk about the different types of treatments that are available for LCA and what kinds of treatments is MeiraGTx working on right now?
Sure. So as I'm certain all that everyone online will be aware that Luxturna is the approved therapy for LCA RP65, and that's a gene replacement strategy. So the majority of the LCAs are characterized by a deficiency that's addressed by replacing that deficient gene and its product with a gene replacement strategy, so gene therapy. And the majority of these therapies are delivered underneath the retina. So as part of an operation into the eye, there's delivery of the replacement gene in a suspension underneath the retina. The other form of genetic therapy that's currently under investigation in the LCA group of conditions is for LCA CEP290. So LCA CEP290, there are 2 main approaches that are ongoing. One is sponsored by ProQR. So that's the approach where antisense oligonucleotides are delivered. So what do? They're repeated serial injections into the jelly of the eye, so they're intravitreal, and they actually target the faulty message of the CEP290 gene, of the commonest cause of CEP290. So it's targeting a specific spelling mistake sequence variant in the CEP290 gene, and it targets the message, trying to correct the message. And because it's the message, you need to keep repeating those injections on a several monthly basis. So that's in phase 3 trial at the moment. It's fully recruited, and one anticipates some readout from that trial at some point next year. The other approach for CEP290 illustrates sort of a third genetic therapy, which is correcting the genetic fault itself in DNA. So rather than the message, actually going to the blueprint. And so that gene editing type approach is being explored by Editas and Allergan, and Casey Eye Institute are one of the principal sites recruiting patients. And that's, as I said initially, for Luxturna, is a subretinal surgery. So it's a one and done approach, if you like. but it's actually correcting the genetic fault at the level of the genetic blueprint. Shall I mention a few things that Meira have in pipeline next, Alyssa?
Yes. Yep, that'd be great.
So sure. So we're also exploring an optimized gene replacement strategy for RP65. We've had some very promising phase 1/2 data that we've presented at multiple international meetings, and we're gearing up for a phase 3 pivotal trial in the first half of next year. So that's for RP65. We have a parallel natural history study in RP65. We also have a natural history study, a prospective natural history study in RDH12. That's currently a site in the UK, so London at Moorfields, and also in the United States, and potentially more sites opening for the natural history study. In terms of a treatment trial, there are plans to initiate a trial in 2022, so at some point next year for RDH12. The other genetic cause of LCA that MeiraGTx have made public is GUCY2D, sometimes referred to as Gucci. So there's some preclinical work that we presented at the European Society of Gene and Stem Cell Therapy, including some retinal organoid work, which is where we have a retina in a dish, which you generate from patients' cells, often skin cells, and that allows you to sort of recapitulate the retinal condition in a dish and try out different therapies. So the data that the preclinical team have for GUCY2D is promising and supports development of a gene therapy for GUCY2D. And the fourth LCA target that MeiraGTx have in a study is AIPL1. So that's a very rare form of LCA, which is a very severe form where children have particularly profoundly reduced vision from birth, and the window of opportunity is really very narrow because the retina tends to degenerate and thin out by the age of 4 years. So treatment needs to be before 4 years of age. So Meira have manufactured that gene therapy and are making it available under a specials license in the UK. So it's for compassionate use and needs to be prescribed by the treating physician. We've treated 4 children to date within that less than 4-year time window. But unfortunately, due to the pandemic and travel restrictions, we haven't been able to see them again to see to what extent the treatment has had any beneficial effect. So there haven't been any safety concerns, but we haven't really been able to determine whether it's working as yet.
So we actually had a question that came in about the compassionate use for the AIPL1, and that's limited to the UK. Is there a possibility that that could be brought to the United States under compassionate use?
It would be a separate regulatory process. So that specials license is for the UK. Now patients can, and all of them have been from abroad, in fact, which is why we haven't seen them. And one of the 4 has been a child from the United States. So it's available to any child globally once we identify another site that's able to administer further treatment. So the site that took on the treatments for the 4 children, Great Ormond Street Hospital in London, at present doesn't have capacity to do more of those treatments. And so we're in the process of trying to identify if there are other sites in the UK that would be willing to undertake more of these types of surgery.
So it's basically closed right now.
Correct. For the time being, we're not open to try and facilitate treatment for any very young children with AIPL1.
All right. Well, that's really interesting, and we'll definitely stay on top of that for updates. And
Sure,
just to be clear, you don't have to live in the UK. You can just travel to the UK if the treatment was available and when it becomes available again.
Absolutely correct.
Okay. All right. Perfect. How does Meira and I guess other companies, how do you decide, what process do you use to figure out which genetic variations you want to focus on?
Sure. So it's that there are myriad things that come into play when different targets are prioritized. Including if there are good preclinical models of the disease that you could target to see if your therapy works. If there are good clinical data in the literature, especially prospective natural history studies, so well-characterized patients, so one has a good sense of how many patients are available with that particular genetic form, how well characterized they are clinically, in terms of what might the window of opportunity be, what might be the ages within which such patients could be amenable to these treatments, what sort of assessments these patients might be able to conduct to try and design that trial, to design the appropriate safety signals, safety outcomes, safety measurements, and then of course effectiveness measurements. So a whole range of different things. It's not simply how common the disease is. Many relatively rare diseases, with RP65 being a good example, have been targeted, and many of the other forms of LCA are being targeted, and there are many other forms of inherited retinal disease that are far more common, but aren't being targeted for a range of different reasons. And I guess it brings me to the other important aspect, given that gene replacement therapy is the most advanced, arguably, of the genetic therapies, most established, if you like, then the size of the gene is key. If the gene needs to be not larger than a certain size, because the viruses that are used to deliver the normal copy of the gene under the retina can only accommodate a certain cargo.
Oh, okay. So a lot of the answers to the questions that you just sort of ran through, do you get those through things like a natural history study, or how do you collect that information in order to decide your variations?
Sure. So natural history studies are really very important, especially prospective ones, because they're far less biased, and the data is often richer and serially collected using specific protocols, so in a more regimented, robust fashion. So that data is more reliable and useful in terms of making those sorts of determinations, and more of designing the trials optimally. So yeah, absolutely, natural history studies are really very, very important. Now, there aren't prospective natural history studies running for all the diseases. So, the next level of evidence that is useful are very large retrospective cohorts of patients who have genetically confirmed disease. So I guess, again, we come full circle. It's very key, the genetics. So people really do need to have a genetically confirmed condition. And that is becoming more available to more parts of the world.
And then not just a genetically confirmed diagnosis, but then also you need to get yourself into a patient registry, right? So that that information is available to the research community.
Absolutely right. Absolutely right. So once that genetic confirmation has been obtained, it's important to get under on the right lists, under the right radars. Seeing your local expert physician is valuable. Registering on some of these national, international registries is also potentially very useful. And knowing where to look for good information. So, the Hope in Focus website will be a good one, but there are other dedicated websites. It's at times too easy to find information online, but it's really hard to be sure if it's reliable, believable evidence. So you need to be mindful where you're looking for that information. But totally agreed, registries are very important indeed. And pharmaceutical companies will often reach out to those registries to try and obtain some of this information.
So talk a little bit about the patient community and your relationship with the patient community as a researcher, and then also within the pharmaceutical industry, and how important the patient voice is in what you do.
Sure. No, absolutely. I mean, there's nothing more important, and I'm not just saying that because I'm on this Zoom. It really is key. I mean, clearly, without the patients, I wouldn't have a job. But it's the patients that teach me about their conditions. I'm always learning from speaking to the patients. And one of the main things I hope my my trainees come away from my clinic is that it's really important to listen to the patients. You know, they're going to give you all the answers you need. Sometimes you need to ask those directed questions, but the patients are key in better understanding their diseases. What are the unmet needs? What's important to them? So it's all well and good to design a study with particular endpoints, particular things to measure in terms of benefit. But if those benefits aren't ones that patients hold high utmost, then it's not a really well-designed trial. So and increasingly, as part of the application to get ethically approved studies, there are regulatory requirements, ethical board requirements for patients to be very much engaged in that design or in the review of the patient information sheets and the consent forms, and rightly so.
It seems, as an outsider looking in, that the importance of the patient community and the patient voice has grown within the research and the pharmaceutical realms over the years. What do you talk a little bit about the trajectory that you've seen just in your career in terms of when you started out in research and how the whole process has evolved and how it's different now than it was maybe 20 years ago?
Sure, no, I think that's absolutely right. I think that's also part of medicine evolving as well. So we're in a very different era from when I started training a while ago, where the doctor knew everything, and the patient just had to listen really, and say thank you very much. So we're a long way away from that. It's a relationship, it's a discussion and a sharing of information. And the doctor absolutely does not know everything. And it's okay to not know everything. That's a relatively new thing, to admit not to knowing everything. So I think there's a real change in the culture. In terms of the academic side, again, the concept 20 years ago of engaging in patients to ask them about what sort of studies we should consider doing or how we should design them, I wasn't on the radar at all. I think it was similar. It was that, well, we know best. I mean, we're the experts, so we're experts. So we don't need anyone else's help. And that's evolved much in the same way as I've described clinically. There's been an understanding that no, it's a team effort, and everyone can bring something important to the discussion and to the design. And without patient engagement, you literally do not have a study. So you need to engage with the patients, and it's a win-win. If they've got a buy-in to the study, then of course they're going to be keener to take part, and they're more likely to have good experiences, and thereby perform better on all the different assessments. And their time is being better spent, and you're gathering more useful information. So yeah, it's black and white.
So among the submitted questions that we had include this one. In quote marks, which drug would you rather take? Based on the therapeutic benefit and long-term adverse side effect risks, would gene editing, gene therapy, or AON-based drug provide the most advantageous treatment?
Sure. So, I mean, we've touched upon all three of those approaches. Glibly, if that was, my child, or it were me, I'd be happy to take anything that works and was safe. So, there are the longer answer is there are pros and cons to all three approaches. There isn't a better or a worse approach. So it's not really a straightforward answer. There isn't actually I want subretinal gene replacement therapy, and all other approaches are not appropriate. So there is the element of pros and cons, swings and roundabouts, and we can touch upon those in detail if you wish to. But also there are some approaches that may only be fit for certain diseases or certain modes of inheritance, the way things are inherited. So the majority of the LCAs are recessive. So there is a deficiency, there is a lack of that particular genetic product. And so gene replacement is a viable approach. There are other dominant conditions where there isn't so much a deficiency, although there can be, but more often there can be a product that is made that is toxic. And so you actually need to stop the production of that toxic product, and then replace it with the product that's not susceptible to the mechanism you've used to mop it up or switch it off. So to some extent, it depends on the disease mechanism. But at the moment, if I had to say what do we have the most evidence available in terms of treating recessive disease, by far the most evidence available is in gene replacement therapy. So there's far more work in the subretinal gene replacement space than there is in gene editing, which is relatively new, but incredibly promising and tremendously exciting. And the antisense oligonucleotide approach, which again is sort of somewhere in between. It's been around for certainly longer than gene editing, but not quite as established, so to speak, as the gene replacement strategy delivered subretinally.
Right. I think sometimes the frustration that we hear from the patient community is, well, if that gene can be fixed, why can't my gene be fixed? And so
Sure.
it's, it goes a lot deeper than that. So
sure, totally understood. And we're in the wonderful world as a clinical geneticist of having more than 300 genes that cause inherited retinal disease. But the flip side is we've got 300 genes that cause inherited retinal disease. So again, at the moment, that sort of gene targeted approach we've been discussing up to now, dealing with the specific genetic basis, is the most advanced. But I'm optimistic that more non-gene specific approaches, sort of broader approaches, will be getting into clinical trial in the near to medium term. And potentially that would be relevant to a far broader range of conditions by definition.
right. We did have questions come in. Any future plans for IQCB1 or CRB1?
Sure.
Oh, and also, I'm sorry, and also CRX associated LCA.
Sure. So in terms of MeiraGTx, I've mentioned the ones that are public and that MeiraGTx have made everyone aware of. So that was RDH12, RP65, GUCY2D, and AIPL1. I mean, in terms of IQCB1, I did actually, thanks for sharing that question beforehand. I did reach out to a couple of investigators just to see if who'd published in this space, to see if they were aware of anyone actively working on it in terms of trying to start a clinical trial. I and they are not aware of anyone, but it doesn't mean there isn't anyone, but I'm not aware of anyone.
Okay.
In terms of CRB1, there are a couple of groups in Holland that I'm sure your callers will be aware of, but Jan Winholz, easier to say, isn't it? So he's been working on gene therapy for CRB1, and I tried to get a timeline from him, but he didn't really give me a timeline. So that group is certainly working towards a human gene therapy trial for CRB1. And I know that Camille Boone, who works quite closely with Jan, is running a prospective natural history study of Dutch patients with CRB1. And I think they've been doing that for 3-4 years and hoping to publish some findings at some point next year. And so as we've alluded to before, I think those things work very nicely in parallel, which is why, again, at Meira, we're running parallel natural history studies. So they are complementary. So I think that's positive news for CRB1, but I can't give more information about timelines. But certainly it's in the pipeline. CRX you mentioned, and so I was aware that there'd been a nice publication from Anand Swarup, who's at the NIH, on CRX. They generated the retinas in a dish we mentioned earlier, the sort of organoids, retinal organoids, a retina in a dish, from patients with CRX. And 2 different patients, if I remember correctly. So CRX is dominantly inherited LCA. So it's the exception to the recessive inheritance of LCA. And so he generated the retinal dish from 2 different patients, and interestingly, used a gene replacement approach, so a supplementation approach. So the type of approach we've talked about that you would use in recessive disease, where you had a deficiency and you were trying to redress that deficiency. And he found that even though CRX has a dominant way of functioning and believed to have a dominant negative, so that toxic approach we talked about earlier, there was a degree of improvement, of rescue, of therapeutic benefit from supplementing CRX. So it makes it interesting to explore potentially a replacement type approach, possibly in CRX patients. So I did reach out to him and ask, are you working towards a trial, or do you know anyone working towards a trial? They currently aren't working towards a trial, so, but he felt there was a French group that may be exploring human trials of CRX. And I haven't been able to get more information about which French group that is, but that was this year. Anand Swarup does some really, really lovely work, and that looked very promising preclinical work.
All right, thank you. That's great. I'm so happy I gave you homework.
Yes.
So we have a couple of questions that came in on the chat. The first one is, I would like to ask about the Muller cell and the implication in the photoreceptors regeneration, and if it is possible to treat only Muller cells with gene therapy in the case of a specific variant of the CRB1 gene, C498506DEL, that won't affect the photoreceptors. So I want you to
try and unpack that. Yeah.
Yes, I want you to unpack that for me.
So LCA associated with CRB1, it isn't just a Muller cell disease. So one of the challenges with CRB1 LCA is in fact that CRB1 is involved in prenatal retinal development. So CRB1 has an important role in the growth, maturation, differentiation, specialization of the retina. Okay, that's before birth. And then it also has a role postnatally in the photoreceptor integrity and interaction with Muller cells. So for CRB1, you often will begin with a retina that is developmentally immature, if you like. So the different layering of the retina is not present. Could you just target Muller cells to provide some improvement in function? I guess conceivably you could. I wonder whether targeting the photoreceptors directly is more likely to be beneficial. There are approaches where people are trying to actually make Muller cells, which remain present even in advanced disease, photoreceptor-like. So actually trying to convert Muller cells into photoreceptors. And that's something that is the subject of several different groups, both academically and also in pharmaceutical companies are looking to do that, trying to convert Muller cells, which remain present till late in retinal degeneration, into photoreceptors.
So you just made me wonder, can you do genetic testing in utero for LCA and for other retinal diseases? Can you do that in utero or no?
Yes, you can. So well, you can in utero, but there is a risk of such genetic testing of a miscarriage. So what can be done, as I'm sure you're aware, is pre-implantation genetic diagnosis. So IVF, so genetic testing of the embryo as part of IVF to determine whether you're going to have a child that's affected. But to do that test, you need to know what was the cause of the LCA in your family, if that makes sense.
Okay. And then is there somewhere down the line in the future possible in utero treatment for something like CRB1?
Sure. So That would be super, super cool, wouldn't it? There are surgeries that occur in utero. So, there are surgeries that occur in utero.
Spina bifida. Spina
Yeah.
bifida is treated in utero now.
Yeah, absolutely. Twin-to-twin transfusion. There are a lot of things that can be done in utero. So you are absolutely right. And partly because the imaging is really so good now that these sorts of interventions can be done. In terms of the type of resolution of if it's going to be to the eye, I'm not sure it's adequate to visualize the retina in sufficient detail to be able to do these types of surgery in utero. I may be wrong, and it's some more homework to do. I can pick the brain of my wife, who's a radiologist and works with a professor of ultrasonography. So we'll get a sense of what sort of imaging you can do in utero, because it would need to be ultrasound. So conceivably, yes. I think technically will be really quite challenging, and will depend on the resolution of the imaging, and also it's reasonably challenging operating on really little children when they're born. So operating on them when they're really that little will be a whole step further. But never say never. Never say never.
Right. Another question that came in is, has the NHS 100,000 Genomes Project been helpful with your current work with IRD patients?
Yeah, it's been awesome. So it's one of the few things I could genuinely say the UK is one of the best in the world. So our genetic testing strategy, our national genetic testing strategy has been really superb, second to none in terms of what you allude to is whole genome sequencing. So characterizing the genetic makeup of patients with rare disease, including inherited retinal disease, and all of their genetic makeup, all of their genetic blueprint. So it's been fantastic in terms of identifying the genetic basis of disease that previously we could not without this type of technology, and identifying novel causes of IRD. So it's absolutely taken the field forward. As with all developments, they're incremental. At the time it was coming on stream, we thought, we currently can solve about 50% of genetic cases using panel testing, so testing a certain number of known genes. And we thought, we'll solve the remaining 50 with whole genome sequencing. It hasn't proven to be as such, as probably was predictable. We're getting up to about 70% of patients being solved using that technology. So absolutely been helpful. Coming back to LCA, being mindful of LCA, we're in a position where the nearly 35 genes now that cause LCA account for about 80% of LCA. So we can solve the majority of LCA, or early onset severe retinal dystrophy.
All right, so I'm going to ask you a question that I literally have no understanding of whatsoever. It came in via email. Is your Ribosome switch technology available to use in treating ocular diseases caused by large genes that do not fit into AAV vectors?
Yes, they're a very, very, very cool question. So MeiraGTx is certainly has that on its pipeline. So the application.
Can you just explain a little bit in layman's terms what we're talking about?
It's having a technology that allows you to switch genes on and off in a very controlled fashion. So it's to be able to really tailor therapy in terms of dosing, either dosing or the timing of it, if you like. So it's really very clever technology, and certainly there are aspirations and work streams to apply it to ocular diseases.
What is it? How is it used currently? What are they turning on and off currently?
It's preclinical at the moment. It's in development to be applied. Yeah.
Okay. All right. And then this
That's a
question,
very well-read reader there, or listener.
yes, we have very
very learned.
Yes, And this question, having an 18-month-old with AIPL1 in the US, is there anything we can or should be doing at this point in hope of benefiting from an ongoing study? Is there a specific registry affiliated with you and your program currently?
Sure. So they'd be very welcome to either get in touch with myself or MeiraGTx directly. So there are patients such as the one you described, who are in contact with us, and I ask them to just reach out again in 6 months' time. Hopefully, we'll have some more information. So absolutely, they can certainly get themselves on our radar.
Okay,
By contacting me. You can give them my email, or they can go via Meira. Yeah.
Okay, so we will do that after the webinar. We'll connect you with the person who asked that question.
Sure.
So I have no more questions that have come in, and we do have a few minutes left. So I wanted to go back to the question that we decided to skip because I was worried about time.
Sure.
And I would love for you to talk a little bit about how you got into this field to begin with, and what keeps you going.
Sure. So serendipity. I wanted to take a break from ophthalmic training, and I'd always wanted to do a research degree. I nearly paused my medical training to do a PhD after I did my undergraduate degree, and was told, don't go out and do a PhD now, you won't come back to medicine. And I think I'm certain they would have been right, but I did listen to them, so I carried on training. But then I did want to take a break, and the first one I found in the adverts was to do a research degree with Tony Moore at Moorfields UCL, who's one of the giants in IRD. I didn't know who he was at that time, but it was advertised. I applied, and I thankfully got it, and I kind of fell in love with it then. Really, he was was and still remains a fantastic mentor, and has been so passionate about the IRD space, despite at that time there always being levied by colleagues being a bit snooty that, oh, there's no treatments, there are never going to be any treatments, why aren't you doing something else? So I got so enthused by the area, meeting the patients, and the families were always so generous with their time. It was phenomenal. It's always so humbling when patients are just so selfless and willing to give so much of their time to help try and better understand the disease and take things forward. And I just continued in that vein for the subsequent decade, carried on publishing, carried on researching with Tony Moore and others. And then when I got appointed, I was appointed off the back of various awards to join the genetics service at Moorfields and take forward the kind of work I was doing in the first 10 years into the second 10 years, which was now designing clinical trials and trying to get these off the ground. So yeah, and never look back. It's been incredibly rewarding, and at times frustrating because it's just so variable, so heterogeneous. But the patients are wonderful and the families. So yeah, and it's a real very privileged to work in this space.
Well, Mike, thank you so much for your time today and for your expertise and your amazing knowledge. And we are so appreciative of the work that you do, and we're grateful to Meira for its support of Hope and Focus. And it's past dinner time for you. So again, thank you so much for your time.
It's my very, very great pleasure. I'd be very happy to have another conversation at another time. But if subsequent questions come through, please do forward them on, and I'll reply by email, and you can then send those on.
Absolutely, we'll do that. Have a great holiday.
Thanks so much. You too. Take care.
Bye.
Bye.